Today I am going to discuss about an approach to a case of poisoning, mainly with the toxidromes. What are the different types of toxidromes, how to identify them, and how we are going to treat them. And just to start with this thing, a 28-year-old male patient with consumption of unknown substance presented to hospital with altered sensorium, diaphoretic, and has passed urine. Heart rate 82, hypotension, saturation is 80%, frothing from mouth with respiratory rate of 45. On auscultation, Krebs and Weiss present. What do you like to do first in this case? So main thing is in the poisoning management, the first thing first comes is rather than treating the poisoning, you treat the patient. So the first thing in any poison patient is airway, breathing, circulation, and then if there are any disabilities like seizures or anything, you treat them, then decontamination, enhanced elimination, and then comes your focus therapy, and if you are not having any this thing, get a tox help. And then once you are done with these things, then you can go and revisit your history, physical examination, toxidrome recognition, and it's a two-pronged approach at this point of time. So whenever a patient comes with a poisoning, first is your ABC. I'm not going to discuss in detail what are we going to do in ABCs. So this thing would be mainly concerned on toxidrome recognition. So steps in management of poisoning would be, most of my talk would be a mnemonic based thing because it's difficult to remember things. So steps in the management of poisoning would be RRSI dead. RRSI dead. R is resuscitation, which is A, B, C, D, E. Then the next R is risk assessment, at how much he has taken, what time he has taken, and what treatment he has undergone, and what is the risk of this patient to go into a severe toxicity. Then is your supportive care and investigations. Then coming to poisoning, it's decontamination, enhanced elimination. If there are any antidotes, please give the antidotes, and way to treat these patients, that is disposition. Now coming to toxidromes. So what are toxidromes basically? Toxidromes is a constellation of findings. Either it might be given through history, physical examination, or some ancillary testings, which may result from a given poisoning. Probably it will give a clue like what type of poisoning we are thinking about. What is the poisoning or what group of poisoning and what are the supportive cares we can give. So first we'll come to see the cholinergic poisoning, toxidromes. Most commonly the chemical associated with that are organophosphates, carbamate insecticides, physostigmine overdose, hydrophonium, some type of mushrooms, and some nerve gases like sarin. So this is a nice flashcard which is saying that, so cholinergic toxidrome, that you have excess of acetylcholine. So acetylcholine is a parasympathetic nervous system which will tell you that all the secretions will be increased. You either see lacrimation, salivation, then sweating, diaphoresis, urination will happen, diarrhea will happen, and at the same time what it affects on the heart and respiration. Respiration, it increases the bronchoria, means respiratory secretions will be increased, and at the same time you will have bronchoconstriction. And on the heart, it will cause bradycardia. Sometimes BP might be normal, but if the secretions are more, it might result in hypotension. Okay. The mnemonic which we can remember, the muscarinic symptoms is dumbbells, or the other mnemonic is sludge. So dumbbells is diarrhea and diaphoresis, urination, meiosis, bradycardia, emesis, lacrimation, patient will be lethargic, and increased salivation. So nicotinic symptoms, two of these symptoms might contradict your muscarinic symptoms, that is mydriasis and tachycardia. So patient might sometimes have tachycardia either due to preponderance of nicotinic symptoms or sometimes due to other reasons like increased metabolic acidosis or hypoxia. Then weakness, tremors, fasciculation, seizures, and patient will be very somnolent. Other way of remembering these toxidromes is like what is happening to our A? What is happening to our breathing? What is happening to our circulation? D, disability, is our pupillary signs and mental functions, what is happening to them. And E is something extras which we can think of it. So most of the time airway might be open, but sometimes because of increased secretions, airway might also get compromised. Breathing, in mild poisoning there will be increased respiratory rate and it might result in bronchospasm and aspirations. Then coming to circulation, your heart rate will be decreased and at the same time BP might be normal or it might go down. And then what happens to your pupils? It will be miosis, and at the same time what happens to your higher mental functions? Most of the patients will be very much lethargic. And at the same time extras. So bowel sounds will be much more active, patient will be passing more amount of urination and diaphoresis, salivation, etc. So this might lead to dehydration as a complications. Again, I am not going into detail of cholinergic syndrome because you have another talk on organophosphorus component. Mainly basic thing is ABC management. Atropine will be our antidote. Benzodiazepines in case particularly midazolam or lorazepam in case patient is having seizures or to calm them out. Bicarb can be used to correct acidosis and pralidoxime in case of organophosphate poisoning. Then comes your anticholinergic syndrome. So most of the time we know anticholinergic means the drug which comes to us is atropine. Okay, but the toxicities, the Toxidrome which comes will be antihistaminics, particularly class 1 of antihistaminics, and psychotropic drugs, that is class 1A antipsychotics, clozapine, and tricyclic antidepressants. Anti-Parkinsonism drugs, some of the anti-Parkinsonism drugs can present as anticholinergic toxidromes, atropine, antispasmodics, and plants, datura poisoning, and Atropa belladonna, that is deadly nightshade. So the mnemonic to remember the anticholinergic crisis would be, as you can see, blind as a bat, mad as a hatter, dry as a bone, hot as a hair, and red as a beet. So blind as a bat because of too much mydriasis, so patient might not be able to see properly. Hot as a desert because patients the ability to produce sweat has lost and patient will become hyperthermic. Mad as a hatter, patient will be confused. Red as a beet because of vasodilatation, skin, particularly skin vasodilatation, patient would look completely flushed. And dry as a bone, as compared to your cholinergic, anticholinergics will have opposite effect on the secretions. All the secretions will be dried out and you would see dry as a bone. So this is one of the mnemonic to remember the anticholinergic toxidrome. So delirium, tachycardia, dry and flushed skin, dilated pupils, myoclonus, hyperthermia, urinary retention, bowel sounds, seizures and dysrhythmias. So again, while if you want to see it as A, B, C, D, E, airway might be open because secretions everything is dried, airway might not be compromised. But breathing, there might be a tachycardia. Circulation, you will have increased heart rate and also increased BP. Disability, mainly your pupil size will be increased and at the same time patient will be completely confused. And extras, everything will be dry. Okay. So if there are completely everything will be dry, patient is more prone for dehydration, hyperkalemia, rhabdomyolysis, and it also inhibits your bowel movements, so patient might go into ileus. So management, again initial management would be airway, breathing, circulation. So cardiotoxicity, particularly some of most, because they are anticholinergics, they increase the heart rate. If it is sinus tachycardia with a heart rate of around less than 150, probably it would be self-limiting. If you just sedate the patient, make him calm, the tachycardia might come down. Some of the drugs like tricyclic antidepressants might have a widened QRS complex or QT prolongation can also, which can result in tachyarrhythmias. In these cases, you need to treat them with sodium bicarbonate. And Then agitation, seizures and hyperthermia usually responds to your benzodiazepines. If your temperature is not coming down, you can just use cool blankets, ice packs and everything. Try to avoid antipyretics. And good amount of IV fluids, particularly to prevent rhabdomyolysis, just to hydrate these patients. The role of cholinergic agent, that is physostigmine, is used whenever your seizures or delirium is not getting controlled with your benzodiazepines. Even with the benzodiazepines, if you are not able to control these things, then you use physostigmine. And if there is a narrow QRS complex, supraventricular tachyarrhythmias, in wide complex, it might precipitate VT. Or if it is a pure anticholinergic, if it is not TCA or other things, then you use physostigmine. And because they are already having a paralytic ileus, in these cases you want to use activated charcoal if patient is much more stable, so that you are decreasing the absorption, your absorption into the systemic circulation. Then sympathomimetic toxidromes. Here, as compared to your parasympathomimetic, you will have increased sympathetic stimulation, which will be like tachycardia, increased BP, and then dilated pupils, similar to anticholinergics, but the difference would be diaphoresis, there will be muscle cramps, hyperreflexia will be present in these patients, and probably in this your bowel sounds will be normal as compared to your anticholinergics. And here also you will have flight of ideas, psychosis, and patients might become paranoid. The drugs which come into this classification of sympathomimetic toxidromes, patient might be in withdrawal state, either an opioid withdrawal, nicotinic withdrawal, alcohol withdrawal might present with sympathomimetic toxidromes. Amphetamines and methamphetamines, cocaine, theophylline and other recreation drugs like LSD, MDMA and Myo. So again, airway open, breathing, increased respiratory rate, circulation, the BP and heart rate will increase, your disability, mydriasis, along with that agitation. The extras which will differentiate, skin will be warm and diaphoretic, bowel sounds will be normal. But if you untreat or if it is prolonged, it can cause dehydration and rhabdomyolysis. These patients can also go into various kinds of arrhythmias at this point of time. So try to monitor them on ECGs. Management. First is symptom ABC, as we already know, airway, breathing, circulation, whether they have been maintained or not. Then coming to control of agitation. Most of our toxicology, the drug of choice for control of agitation and seizures would be benzodiazepines, either lorazepam or diazepam, because they are more long acting. And if patients are too much agitated or they are not responding to any of these things, then probably paralyze them and tracheal intubation might be necessary. But while doing tracheal intubation, please avoid succinylcholine because it can cause deadly hyperkalemias. Hypertension, how to treat? Because sympathomimetic action, heart rate will be very high and patient will be very much hypertensive. Again, benzodiazepines will calm these patients. In case if they are not able to calm down, then you give peripheral vasodilators rather than acting on the heart, that is nitroprusside and phentolamine. Don't give pure beta blockers, because if you give a beta blocker, heart rate will come down, but there will be a pure alpha action which will increase your afterload and thereby decreasing your cardiac output, and which might in turn can cause MI and other things. Hypothermia, again benzodiazepines will help to reduce the temperature, and other things are evaporative cooling measures, cooling blankets, and in case if temperature is going very high, like more than 41 degrees, you go for neuromuscular paralysis. So monitor also for end organ ischemias like MI and CVS in patients of sympathomimetic syndromes. Then how do you do fluid resuscitation? Because in these patients you are having hypertension and tachycardia, so all your markers of fluid resuscitation might not be proper. And once the sympathomimetic action comes down, patient might be completely dried out. So tachycardia, hypertension and associated cardiac dysfunction normally will impede your assessment of fluid resuscitation. Sometimes if there is severe lactic acidosis, rhabdomyolysis are present, very aggressive fluid resuscitation is required. Make sure that you don't overload this patient initially. Soda bicarb might be used if pH is less than 7.15, and particularly body packers, if there are cocaine body packers or amphetamine body packers where the capsule has been ruptured, then you might need to do a laparotomy. Then coming to sedative toxidromes, the drugs which come in these categories are opioids, benzodiazepines, barbiturates, baclofen, clonidine and GHB. So most sedative toxidromes is like A, B, C, D, E. Airway, patient might be alert or might respond to just voice, most of the time either to pain or completely unresponsive in case of severe this thing. And breathing, respiratory rate will be reduced and saturation will also be reduced, and circulation, heart rate and BP will come down, and the pupil size, only in case of opioids it will be miosis, otherwise it will be normal, and it might go into hypothermia also. So just remember these opioid toxidromes: CPR 3H, coma, pinpoint pupil, respiratory depression, hypotension, hypothermia and hyporeflexia. And the same opioid toxidrome A, B, C, D, you can see where in the D you will have meiosis and depressed mental status, and at the same time patient might go into paralytic ileus and also sometimes rhabdomyolysis also. Management, because it's sedatives, airway, breathing and circulation. If they are going into hypothermia, rewarm them. Opioids, particularly if it is acute intoxication during the procedure which we are given, or if there is a cardiac arrest or severe respiratory depression, then you give naloxone. Barbiturates, alkaline diuresis and hemoperfusion, and benzodiazepines and clonidine, mostly it's a supportive care. If patient goes into, yeah, just 2 slides, sir. Opioid withdrawal, then you will see sweating, mydriasis, more like it's combination of both sympathomimetic and cholinergic crisis. You will be sweating, mydriasis, tachycardia, goosebumps, muscle cramps, at the same time vomiting, urine and diarrhea. So treatment of choice along with this thing, supportive care, the treatment is methadone. Serotonergic syndrome. So mainly a triad of altered mental status, hyperreflexia and diarrhea. Probably how do you diagnose is mainly by Hunter's serotonin toxicity criteria. So spontaneous clonus, if it is there with a background injection of serotonergic injection, then yes. Or inducible clonus or ocular clonus with diaphoresis, then yes. Tremors with hyperreflexia, then yes. If none of this is there, then it's not a serotonergic toxicity. Supportive care is the treatment of choice along with IV fluids. In case they are not responding to benzodiazepines, then you can use cyproheptadine, which is a serotonergic antagonist. Extrapyramidal symptoms, mainly rigidity, opisthotonus, trismus, hyperreflexia. And then at last you will come as a neuroleptic malignant syndrome with a like 4 cardinal symptoms, that is altered mental status, increased temperature, rigidity and autonomic instability. As you could see, it's a lead pipe rigidity with brain which has gone toast. So differential diagnosis for these things would be serotonergic and anticholinergic. You also need to remember these things: osmolar gap, anion gap and saturation gap. These things are, I have just mentioned the drugs which can cause increased osmolar gap, widened anion gap, metabolic acidosis. This thing mnemonic would be cat mud piles, and saturation gap, and there like QT prolongation and antipsychotics. These are all I have just included in the slides with all the mnemonics. If you want, you can have my slides. That's all. Thank you.